Good morning. I'm Jeff Miller. I'm one of the co-directors of Grand Rounds with Doctors Kate Elkington and Christine Denny. We're really pleased that you're able to join us today. I have just a few announcements before we begin. First is about next week's Grand Rounds session. It is the Eric Hadar Distinguished Lecture in Psychiatry, and it will be given by Dr. Roger Weiss, Chief of the Division of Alcohol, Drugs, and Addiction at McLean Hospital and professor at Harvard. The title of his talk is Integrating Pharmacotherapy and Behavioral Therapy in Treating Patients with Substance Use Disorders. And following the lecture, we'll have a new lunch set up. It will be a lunch specifically for trainees at all levels of students, residents, postdoctoral fellows who would like to have lunch with the speaker. That will take place in the multipurpose room on the 6th floor from 12:30 to 1, and registration is required in advance. There will be an email sent out soon with a link to register for the trainee lunch after next week's Grand Rounds, and that will be an ongoing lunch going forward for in-person Grand Rounds. For today's session, I want to encourage everyone to ask questions of our speaker. You can do so by posting a question in the Q&A feature at the bottom of your Zoom window, not the chat. And we really encourage you to ask questions yourself. So at the end of your question, please write, "Can ask question myself," or "prefer to have my question read." If you're open to asking it yourself, we'll temporarily promote you to panelist, which just means that we'll be able to see you on the Zoom, camera on, or hear you on the Zoom, camera on or off, to speak directly with our speaker today. And also, we would like to prioritize trainee questions. So if you are a trainee, please put the word trainee at the beginning of your question. Now I'm very pleased to hand things over to Dr. Claudia Lugo-Candelas, Assistant Professor in Child and Adolescent Psychiatry, to introduce today's speaker, today's talk is sponsored by the Office of Equity, Diversity, and Inclusion in honor of Native American Heritage Month.
Hi, everyone. It is my absolute pleasure to introduce Dr. Kamilla Venner from the Chitna village of the Atna Athabascan People Incorporation. Dr. Venner is a clinical psychologist and associate professor of psychology at the University of New Mexico. Her research aims to reduce the substance use health-related inequities that American Indian and Alaskan Native people experience. Along with her team and community collaborators, she explores ways to culturally tailor evidence-based treatments to improve acceptability, engagement, retention, and outcomes for American Indian and Alaskan Native people. Dr. Venner is an expert in evidence-based treatments and motivational interviewing and community reinforcement approaches with Indigenous populations. Her body of work is diverse. It encompasses studies that include digital interventions, measurement development, while always centering community, culture, and people's lived experiences. She's published broadly, including studies of substance use and the role of trauma, racism, and tribal identity, and most recently is testing culturally centered implementation models to improve adoption of evidence-based treatments, such as medication treatments for opioid use disorders in American Indian and Alaskan Native programs and communities. As many of the people in our own department who do this kind of work will know, this work is incredibly challenging. As it turned out, that it's very hard for community programs to adopt evidence-based treatments or even to enhance things that they have going on in the moment. She enjoys learning from the communities with whom she partners and looks forward to many more collaborations in the future. We're all privileged and grateful to have Dr. Venner presenting her work to us today, and we can't wait to hear from her work just now. So join me in welcoming Dr. Venner. I'll hand over things to you.
Thank you so much, Claudia, for that beautiful and generous introduction. I want to thank Karen Cruz, who I'm sure many of you are aware of, for all of her help in making sure that this happened. And a shout out to my research collaborator and dear friend, Amy Campbell, who I think put my name forward. And thank you all for joining me today. I really appreciate it. It's really nice to be honoring Native American Heritage Month, and I appreciate that you do that and are willing to hear about my line of work. I do have to start with a conflict of interest disclosure. I have a conflict of interest management plan here at the University of New Mexico due to conducting research on evidence-based treatments and also providing consultation for those same evidence-based treatments. often for other folks doing this kind of research, but sometimes for tribal communities as well. And I want to start with a land acknowledgement. And I know these can be kind of tricky and people are struggling with them. And I also struggle with them, I will say. So even in looking and preparing for this one, I thought I would want to honor the ancestral lands that Columbia University sits upon. And when I looked up in Canada, there's a wonderful website there. They listed like 4 different places, but I've been told that it's more customary to honor the Lenape people. So I want to pay respect to their elders, past and present, and acknowledge historical and present trauma, as well as historical and present resilience among these people and others. We honor the children and future generations to come, and we invite you to consider how you might honor these Native communities or others where you live and work. And there's the site that I use to find some of this information. I wanted to put some pictures up of their beautiful artwork, but they all seem to be copyrighted, so I didn't do that. So today I'm going to just give you a broad overview of my work, just to show you that there's a lot of different work that needs to be done and has to be done in order to do good research. So I'm going to be sharing some of my assessment validity work, some positive stories of resolving alcohol use disorder among American Indian Alaska Native people, just a hint at some of the cultural tailoring we've done with some of the treatments, and then end with just a hint at the culturally centered implementation work I'm doing now, one in partnership with Dr. Campbell from Columbia. A little summary, and then future work and questions, time for questions. So you'll be seeing bridges from New Mexico that I took pictures of, so they're not copyrighted in New Mexico, because I feel like my whole life and my career have been about bridging worlds. So I bridge the worlds of my heritage. So on my mom's side, I am from the Chitna village tribe, from the Ahtna Athabascan people, which is also our corporation, and from the Caribou clan. So if I have any relatives out there, greetings to you. And on my dad's side, I have mixed European heritage. So I'm bridging those worlds. And, you know, formal education in the US is very westernized. So I'm constantly bridging kind of Western science with Indigenous science. And then also when we find our research results, especially around treatment or really anything, assessment, we want those to get out into the community to do the most good, but it's very difficult to do that. So now I'm trying to bridge research to practice with implementation science work. And my driving questions have really been around how generalizable that's hard. The generalizability of our psychological constructs. So that's around assessment, different models, and constructs that we have, and also our treatments, and then how we actually even go about implementation. Also, what should American Indian, Alaska Native people and other Indigenous groups and other really non-Western people around the world do with the best from our science? I know, work very hard on our science, but what should they make of it? How should they approach it? And what should they do? And so I think that's a lot of my work in trying to work with the communities to see what is their knowledge base, what is you know, what do they bring, and what can we bring, and how can we bring those together as partners? And then finally, how might my work inform the science for the mainstream? So across my career, I have felt that a lot of times people, if you're not doing work with American Indian, Alaska Natives, it might seem questionable about whether you need to attend talks such as these. So I really appreciate you did attend today. And I do feel that my work does have something to do with, does improve our services for the mainstream population as well. You may know about this, psychology and the weird samples. So weird stands for Western countries, educated, industrialized, rich, and democratic. So weird countries represent 12% of the world population, but 68% of our studies come from samples in the US, and 96% of studies use samples from weird countries. So I feel like, oops, sorry about that. It's having one of those issues where my screen is getting blocked here. Well, American Indian, Alaska Native populations offer a wonderful venue to test the generalizability of our constructs. And I think we need to do a better job of getting outside of our weird countries and not just assuming that anything that we find with our weird samples automatically applies to other cultures. So just a little bit about the health disparities and inequities. This is how our grants start. A lot of our papers start. It's an effort to highlight the need for work in this area and sort of justify our work. So in the past year, this is from new SAMHSA 2021 data, you can see that American Indian Alaska Natives had much higher rates of alcohol use disorder than other racial ethnic groups, with Asian here at the lowest rate in the past year. So it's definitely a problem. When you look at any SUD, it gets even worse. So you can see that Asians here have the lowest rates, and American Indian Alaska Natives, unfortunately, have the highest rates. So that would be any alcohol use disorder or other drug use disorder combined. So it's definitely a problem, and you can see where some of the negative stereotypes come about, because this is the information that gets spread in every publication. I mean, through the news, through movies, media outlets. So I just want us to think for a moment about how we have inherited various messages that may be correct and may be erroneous. So one final disparity slide about opioid overdose mortality. And American Indian Alaska Native here at the far right around 2020 are evidencing the highest rates of opioid overdose mortality. And so that's, everyone is experiencing this opioid overdose epidemic. But you can see that we've sort of been right on top of the line of non-Hispanic white people who are finally trying, slowing down a little bit, but much more needs to be done for everyone, really. So just a moment to invite us to think about, why are there these health inequities? Is it a biological reason? And I just have to say this because so many people continue to have these negative and erroneous stereotypes about American Indian Alaska Natives and alcohol and other drugs. So there is no scientific evidence that American Indian Alaska Natives differ in rates of metabolizing alcohol. And I'm not sure, if I were there in person and you were in person, we could maybe even raise hands to say, how many of you already knew that and how many didn't. Similarly, there are no special genetic predisposition for American Indian Alaska Native people to develop an alcohol or other substance use disorder. We have the same genetic, risk factors as anybody else. And this is unfortunate that these messages continue to, propagate. We have such a hard time disseminating correct information, and sometimes this incorrect information just is out there and people glom onto it and will never let go of it. And Dr. Monica Skews does some of this work that American Indian Alaska Natives have internalized this horrible message that we have a genetic predisposition, and we do not. So I would probably also ask you, how many of you knew that? And we'd encourage you to share that corrective information if you haven't already. So what is the reason for these? We would argue that social determinants of health. And I know that some of your areas are so good at looking at this. Psychology is not good. I don't think psychiatry is as good either as a field in general. social work, there's public health, community health, there's some other groups that do a much better job. But American Indian, Alaska Natives, on average, not every tribe, not every person, but on average have much higher rates of poverty, much lower quality of formal education, a lot of risk factors in neighborhoods. So those could be being in a food desert, having an unsafe neighborhood, not having sidewalks and parks. Could be that it's a long distance to get to a level 1 trauma center. So, poorly maintained roads or poor lighting, things like that. Social context. So that could be, any of these things, and discrimination, prejudice, bias, oppression, things like that. Access to healthcare. So American Indian Alaska Natives do have access to the Indian Health Services, which is woefully underfunded. I think has half as much, maybe, what was it, $4,000 per capita versus Medicaid, which is like $8,000 versus the VA, which is like $12,000. So woefully underfunded. And not every place has access to that. So the state of California doesn't even have an Indian Health Service proper. And then historical trauma, which you may or may not have heard about, but that would refer to a lot of the U.S. policies toward American Indian Alaska Native tribes. So boarding schools, atrocities, interfering with parenting, attachment, the culture, which, couldn't speak the language. It was illegal to practice many Native American religions, not being able to vote. And that historical trauma, Maria Yellowhorse Braveheart says, is from the history to the past second, right? It comes into the current day as well. And a lot of people want to talk about historical resilience as well, because not everyone's having trouble, of course. There are a lot of American Indian Alaska Native strengths in terms of cultural identity. This is just a picture I found actually on, and this is like a lodge where we would have a lot of our potlatches up in Alaska, our community gatherings. And this looks like an honoring ceremony by the youth here. Cultural identity can be a strength, spirituality, which we'll talk quite a bit about today, having a sense of community and connectedness, and not just to each other, but to the land and to the cosmos. Also, I would ask how many of you are used to talking about rates of abstention from alcohol. And this is past month. This is also from SAMHSA in 2021. And it varies across the years. So I think in 2018, American Indian Alaska Natives had the highest rate of abstaining from alcohol in the past month. But in 2021, Asian Americans have the highest rates, getting about 68%. And you can see that non-Hispanic white have the lowest rate of abstaining. So why do I bring this up? Well, I hope you will share this as educators, share this message. This is an empowering message for any of your clients, right? From any group, if they're struggling to overcome an addiction, they should have a lot of people that would support sobriety in their networks. So I think this is wonderful information to check into and share with clients, and let them know that that is also something that they can know and incorporate into their identity. And just a bit on ethically working with tribal partners before we get into my work. There are 574 federally recognized tribes. There's other state recognized tribes and then unrecognized tribes for various reasons. And they're sovereign nations. So they have their own governments. When I go to work with the tribe, I meet with the governor and his council to talk about the work and to obtain their permission. So you are seeking tribal consent for the research. Usually I'm seeking their consent to submit grants. So you can see that this adds a lot of time and energy. And then there's tribal approvals all along the way. So if you make changes to your protocols, when you want to disseminate your findings, you check in with them first. And then extending confidentiality and anonymity of an individual participant to the community. So without their permission, there's no sharing of which tribes you're working with. So I may say a Southwest tribe, for instance, instead of the actual tribal name. There has been, of course, many instances of harmful research conducted with American Indian Alaska Natives. And there's one infamous, I should say, 1979 Barrow study, where they were working in Barrow, Alaska and doing surveys. And then they just had a media blitz to share the findings of extremely high rates of alcohol problems without checking with the community first. Everybody came in and it harmed that group for quite a long time, and even like insurers pulling out of that area. So that was terrible. And you think, okay, well, that's a long time ago. Well, in 2010, they have a Supai tribe in Arizona State. We're also conducting work without tribal permission that we're challenging their own beliefs. So these things continue to happen to today. So that's why a lot of times you have to go to the tribes and make sure that you are conducting ethical work and that you have a good understanding of your results and the best way to present those. So we do work with community-based participatory research approaches so that we're working to decrease power differentials between an academic partner and a tribal community, try to have as equal a partnership as possible, working to increase their research capacity as well as learning from them. So it's a bi-directional learning, sharing the findings, making sure it's something that is important to them and that it is for the betterment of the community. So they get tired of just being told all the negativity. So let me move into the first line, which is around assessment validity. That assessment really, comes from a Western culture, that psychology was founded by non-Hispanic white men. Assessments are typically developed by non-Hispanic white, though that's changing for sure. So that's wonderful. They're often tested for validity with non-Hispanic white participants. And so there's often unknown validity for people who are not from a non-Hispanic white background. So some of the different work I've done, dating back to my master's, was looking at models for the progression of alcohol use disorder. And I found with one Navajo sample that was more traditional, it really didn't fit that well, and not at all for the Navajo women, because it had been developed with white men in an AA group. This is Jelinek model for those of you who know. More recently, one of the graduate students, Kelsey Serrier, who is no longer a graduate student and working in Boston, BA, she evaluated the validity of the DSM criteria and found a very good fit there. As part of my dissertation, I tested an orthogonal measure of cultural identity with a sample in California. From Cindy Eller's data. She was generous to share those data with me. And so that was great. And then today I'll talk about working with a spirituality scale with my tribal partner here in the Southwest. I just want to talk about spirituality and how it fits with a more Indigenous holistic perspective. So this credit for this diagram or picture is from the NIH HEAL initiative. So it's, you can, for those of you who are familiar with seeing a medicine wheel, this is kind of like a medicine wheel. It's based on that. And, when we think about our models for addiction and what we're interested in, a lot of times we move to the biology and look at genetics and look at the brain and try to understand why people, how the brain changes with substances on board, that sort of thing. We might look at psychological factors like comorbidity of, mental illness, impulsivity, things that are happening within the individual, coping skills. But we don't often, in our evidence-based treatments, look at social factors. So how do we explicitly include experiences of discrimination, for example, or look at social determinants of health and make sure, that somebody has food security, housing, other things like that. And we definitely don't have spirituality represented in our evidence-based treatments in an explicit way, except for the 12-step facilitation, which did not come out of, psychologists or other people that develop these treatments. So we tend to separate these out and be more reductionistic, but an Indigenous view is more holistic, and you'll see how that continues as a theme throughout the work. So I brought the daily experiences of spirituality scale to my tribal partner here in the Southwest, thinking, I know spirituality is important. I know they don't want to just look at outcomes of like reducing substance use. They want to see that their people are healing and doing better in many ways. And one of them would be spirituality. So I brought this scale. It had wonderful psychometrics, had been tested in so many different religions, and even with people who were agnostic or atheist. So that some example items are: I feel God's presence, I experience a connection to all life, I feel deep inner peace or harmony, and I'm spiritually touched by the beauty of creation. So I thought, this is fantastic, land-based people. And so I brought it to my partners, and they were like, 100% no. This is not how we talk. This doesn't make sense for us. And so I got very worried as a researcher, like, what am I going to do now? You're taking my really good measure and throwing it out the window. So they worked with it, and they come up with their own items. So instead of 16, there's 12 items. And some of the samples are: I believe life is sacred. All things are related to one another. I believe everything is alive with the spirit, and I'm spiritually touched by participating in my faith. So fortunately, I had a wonderful graduate student who's now at the University of Minnesota, Duluth, Brenna Greenfield, and her colleague at the time, Kevin Halgren, who's in Washington, I believe at University of Washington. And they ran the psychometric properties of this new adapted measure. And they found a 2-factor solution, and it looked like one factor was more about spiritual behaviors, and I'll show you some examples in a moment, like prayer, and the other factor was more about spiritual beliefs. And there were some interesting correlations with the baseline data, so that higher spiritual behaviors were related to lower past month alcohol, cannabis use, greater ethnic identity, greater likelihood of preferring American Indian spirituality. Factor 2 didn't have any associations. And we looked over time to look at spirituality as an outcome, which doesn't often happen. And we looked at, they found increases from intake to 4-month in the more spiritual behaviors. And here's a couple items: I wake up early and pray to the creator or ancestors. I find strength in my faith and spirituality. And factor 2 had significant increases at the 8 and 12-month follow-up. And one of the items was, I believe all life is sacred. So the partners were very happy with that. And so this adapted spirituality scale offered good psychometric properties. The spiritual behaviors were correlated with lower substance use. And that's consistent with the literature that, even just saying I'm checking religious affiliation is very protective for mental health and substance use outcomes. Spirituality increased over time. So this is something that other folks maybe can use with other tribal populations, and have done so. I just want to move quickly into another study I did for my first K-23 under Bill Miller and Phil May. And this was looking at positive outcomes to try to counteract some of those negative stereotypes, looking at American Indian Alaska Native people who had resolved an alcohol use disorder for at least 1 year. So looking for success stories. So here's another beautiful New Mexico bridge. So the paper, we ended up titling it "Whatever It Takes or All That It Takes," which was one of the quotes from the participants. Okay, this is really needing to be moved. Hide the video panel. Nope. I am not sure how to get rid of this little bar. I have been able to move it in the past, so I don't know. Okay, there we go. So for this sample, we had 55 American Indian Alaska Native people, 56% were male, 51% had learned English first, but so that means the other almost half did not. And 66% had sought traditional healing. So there was a range of these behaviors, but you can see that they were pretty enculturated, right? More traditional. So we just asked him, how did you know you had a problem with alcohol? What did you do to overcome your alcohol problems? And how are you doing now? So we used consensus coding. We had 5 coders using in vivo, and this was published in Cultural Diversity and Ethnic Minority Psychology. Okay, so just a few highlights from this. Some of we divided it into motivating factors, of which there were 8, but here's 3. So some of the motivating factors they listed were children and grandchildren. And the quote is, I just kind of did it for my daughter and my granddaughter too. So I didn't want her to remember me as a drunk grandpa, but as her sober, fun grandpa. So, thinking about how they were going to be perceived by their grandchildren. Others, negative consequences. So seeing other people experiencing negative consequences. They said, I've seen people die. That's what made me think about quitting. And then legal consequences. I thought I was going to be released, but the lady was adamant with her decision that she was going to have me learn my lesson. And God bless her, because as a result of that arrest, I have been sober now for 11 years. Of course, there were folks that legal did not motivate them for a long time as well. And then they had various actions. I was interested in what did they actually do. So we found 11 actions, and here's 4. Formal treatment was something that happened much, much later in their efforts to change. But one of them said, I realized treatment was for Native people too, and not just for the white man. So that was good. And, you can see that maybe they had internalized like treatment might come from this Western world, and maybe it's just for the white man. 12-step models. It's just such a relief to know I'm not in this by myself. So just really appreciating that camaraderie and that fellowship. Spirituality. The only thing that I really think is very, very vital about getting sober and maintaining sobriety is to have that spiritual base, whether it's organized religion, Native American religion, whatever it takes, or all that it takes. So this person talked about trying different things, which is very common, right? It takes probably at least 8, on average, 8 serious quit attempts for someone to really resolve an addiction often. And so this person said they tried something else, they tried something else, and then they thought, well, we just better try everything. So whatever it takes, or all that it takes. But the spirituality was had to be in there. And then finally, just being with other American Indian Alaska Natives seemed to be a good action. I think it was easier to go to a rehab setting with only Native Americans. It was just more comfortable. We could relate to each other. So sometimes knowing who's providing the services and also who else is receiving those services can be helpful for people. So in doing this work, I often think about what is common across cultures and then what might be a little bit more unique. So, commonalities and motivations, people often refer to friends and family, legal issues, children, medical problems, a doctor's warning definitely can help, even if you have to do it over and over. And, work, employers intervening. Actions, formal treatments, common 12-step meetings, Christianity, change in a social network. So sometimes leaving, moving, get increasing social support, keeping busy, distracting oneself, and physical activity. Some of the more unique things that I hadn't heard about before was seeing the negative consequences in others, but you may have heard that too. And then some of the actions like seeking traditional healing in addition to other treatments or solely. Although for some people it didn't make sense because of their level of cultural identity, and spending time with other American Indian Alaska Native people. So I like this study a lot still. It's a positive message. People don't often talk about American Indian Alaska Native people resolving alcohol use disorder, and it's such an important message to get out there. I know a lot of tribal programs do have stories of people who have recovered, so they're trying to get the message out there as well. There's, of course, more than one path to recovery, and what worked for one person didn't work for another person. So some people really enjoyed traditional healing, some people didn't. Some people, one legal problem really made the difference, and for others, they were in and out of the legal system. All of my participants were in abstinent recovery status. There was not one moderated drinker, and that may have to do with there not really being any socially sanctioned, approved reason to drink alcohol among most Native tribes. Most tribes have are practicing prohibition on their land, so you cannot bring alcohol onto the lands. So anyway, I thought that was really interesting because in the general population, about close to 20% of people with alcohol use disorder can moderate their drinking successfully. Yeah, lots of different motivations were in there. The message is keep trying, don't give up, for the person and also for the people around that are trying to support someone to move into more health. Okay. I am going to skip along here to culturally tailoring treatment. So now I have a very plain bridge here, and this would be the unadapted treatment bridge here. Very functional, right? It's going to do the job. So one way to address these substance-related health inequities is to use evidence-based treatments, or what I often refer to as EBTs. Funding agencies require EBTs, so that's been interesting. I think only recently there's been some more funding opportunities to bring in more culturally based healing, traditional healing, looking at some other ways of maybe bringing Indigenous science to light. So this bridge, though, sometimes, I guess I didn't put it in here. Sometimes I have a more, dilapidated bridge that maybe doesn't look quite as safe. And so that maybe from a person who's more traditional, like the one person that said, oh gosh, I guess treatment is for Native people too. Some of these evidence-based treatments may look like a bridge that's not that safe. Not really sure if it's going to get you where you want to go and work for you. And so that's, I think, also a good reason to try to do some cultural tailoring. Some tribes and folks see a real clash in between evidence-based treatments and more traditional healing methods. So evidence-based treatments tend to be dyadic, where there's two people in the room, or maybe a couple, or maybe a family. But traditional healing can happen on the individual level. Family or whole community can come out and participate in traditional healing. Evidence-based treatments, unfortunately, are still pretty stigmatized, whereas traditional healing is more an admired activity. You can be proud of, and people are happy for you. Evidence-based treatments are secular, as I've said. Traditional healing, of course, is sacred. And in evidence-based treatments, there's not any explicit way of bringing in American Indian, Alaska Native culture, right? So people like Joe Gahn and Calabrese have said, putting a Native person into an unadapted evidence-based treatment, it could be seen as a way to further assimilate into Western culture. So let's let that sit there for a second. It's pretty strong. Whereas if you go through traditional healing, then of course that's preserving culture. Kathy Berlew had a wonderful paper, and I'm just highlighting for the reasons she highlighted, where there are reasons to culturally adapt an evidence-based treatment. So of course, if that evidence-based treatment is found to be less effective with a different group, then that might be a reason to culturally tailor that treatment or find a whole new treatment, right? So that has been found with treatments that were less effective. The one I have here was with African-American men. And so they adapted it in partnership with African-American men, and it was more successful. If the evidence-based treatment is iatrogenic, and we've found that where you go through the treatment and you actually get worse, then maybe you're going to throw that one out or culturally tailor it depending. If the adaptation would increase the attractiveness, so engagement, retention, and outcomes, and that could be a good reason to culturally tailor. So for my tribe, they were like, nope, unacceptable. So if the evidence-based treatment is unacceptable, then that might be a reason to culturally tailor as well. I guess I would say sometimes it's hard to get those data that the evidence-based treatment is less effective with a certain group because maybe they just didn't even come, or you didn't have enough people to even analyze those data to make anything of that. So these questions really need to be part of the hypotheses and part of the aims, not something that's just done as a secondary analysis. So one of my studies was a randomized controlled trial. It looked like the second randomized controlled trial of psychosocial substance use disorder treatment with American Indian Alaska Native people from NIDA. So the tribe approved, but it had to be culturally tailored. I hired 2 bilingual counselors and a bilingual research assistant, partly for sustainability and partly because I knew that they would be more familiar with the culture too, right? And it's a way of giving to the community that they can use those treatments if they so choose. So we had 79 participants, 68% were male. And so it's a relatively small sample, but for this kind of work, it's a pretty usual size, partly because these are often small tribes and small populations. So treatment as usual, there were 41 in there, and we used motivational interviewing in the community reinforcement approach. So we called it MICRA. And this, we had a little contest for artwork, and this was the one that they chose here, this beautiful artwork here. And this was published in Addiction. So some of the things they told me that they did to adapt were to change how they introduce themselves. And so this wasn't something we had talked about, and they just told me later that when the client came into the room, they greeted the spirit within that person. So it wasn't like in a Western way, hello, Mr. So-and-so, or hello, you know, Kamilla or whomever. They greeted the spirit in that person. And this is something I think might be hard for a lot of Western providers to adopt. Where you might have heard of this, maybe if you're familiar with yoga and namaste, that's a wonderful greeting where it's like the highest part in me greets the highest part in you. And I think about clients coming in to a place that's stigmatized, feeling stigma, feeling shame, and then somebody greets them by the best part of them, right? I just can't imagine any way that we could do that without incorporating kind of a spiritual realm to our work. So I think that is just absolutely incredible. I don't know how you could feel any more welcomed, right, than somebody, if that was okay with you. Not every Native person probably wants to be greeted by their spirit, but I just think it's pretty beautiful and something to consider. They also introduced themselves in terms of their heritage and their clan system. So like I introduced myself, I am from the Chitna tribal village up in Alaska, from the Caribou clan. And then if I learned that somebody else was maybe from the Eagle clan, then we would understand what our relationship was, which governs a lot of behavior. So, you know, how people help each other out, how people give gifts. It's really a beautiful system, and who you can marry and who you can't, a lot of different things. So then instead of calling the client even by their name, they might refer to them by a relative term, right? Oh, come on in, my auntie. It's so different of a relationship, right? We are one, you are loved, we have this connection. There's a lot there that I don't think we learn about in our Western institutions, but I could be wrong, and I'd love to hear your experiences. And I'll just mention, this is a little pendant that my dear late grandmother beaded for me, this polar bear. It's very special to me. Another quick adaptation has to do with motivational interviewing, and you may be familiar with the rulers of importance and confidence. So quick ways of checking client motivation to change is to ask on this linear scale here from 0 to 10, how important is it for you to make a change in your opioid use, right? And so they could say 0 is not at all important to 10, extremely important. And when I did this work back in, 2005 or 6, with a focus group of 10 different American Indian people of varying levels of formal education, varying levels of traditional cultural identity. We thought, I think most people don't like these numbers, like rate your pain, or I guess we're getting away from that, but I don't know how many of us really do like this number. I certainly know in giving birth, you're like, well, this feels like it could be a 10, but it could get worse. So what number is it's like sort of confusing, distracting. So they said, well, why don't we just use some words, and we could use pictures. So some of the words were like, it's not important to make a change. You haven't prepared the ground for planting. So that would be like 0, 1, or 2, right? 0, 1, who knows? To you're unsure about making a change. A seed is in the soil, but it hasn't been watered. So kind of bringing in a metaphor here. It's important to make changes, moving up the scale. Your plant just broke through the soil. To it's extremely important to make changes, and your plant is ready to be harvested. So I think just looking at this is a beautiful, attractive thing to look at. And also just inviting further adaptations. So green chilies, well, I didn't know about those till I moved to New Mexico. That wouldn't make much sense back in Alaska, my home state. So you have to come up with something that makes more sense. I worked with one group, set of researchers that were trying to reduce obesity, and they were working with mothers. And so as I was training them, they said, what if we did, the metaphor was making baby booties. And so they came up with something totally different. So this is available to anyone to adapt as they see fit to just hopefully connect better with your clients. So what were the results? It was sort of sad at the time. Culturally tailored MICRA did not outperform treatment as usual. There were no significant differences. You can see there was like this little baseline difference, even though we used randomization. But fortunately, everyone did get better. Made it hard to look at moderators and mediators, but it did demonstrate that this tribe was open to learning and trying on an evidence-based treatment, but of course only if it was culturally tailored. So then you kind of wonder, well, what happened? Did the cultural adaptations reduce the efficacy or effectiveness, I guess? We wondered, maybe they weren't delivering it to fidelity. What happened? We don't entirely know. They also started with very high rates of percent days abstinence. So that also made it harder to detect changes. And that didn't seem to be related to being in an institution or anything like that. I think it's more the style potentially of not using necessarily every day for everyone. So there were no significant treatment effects. That often happens when there are two kind of active treatments. So it sort of fits into the literature that culturally tailoring treatments is effective. So that was good. But a lot more work needs to be done with larger populations across different groups. So hopefully more people will pick up this line of work and try it with larger samples. So finally, kind of rounding the end here, which is good. Moving on to my culturally centered implementation work. So another beautiful bridge in New Mexico. So one of my projects that I am partnering on with one of yours, Dr. Amy Campbell, and also Dr. Margaret Passionwolf is also on the line, and she's our wonderful, I can't remember if it's research coordinator, but right-hand person who is so effective and smart and wonderful. So we're culturally centering the delivery of medication treatment for opioid use disorder with American Indian Alaska Native programs to address those terrible health inequities you saw earlier. And as you may know, I'm sure I know there's a lot of implementation science happening out there at Columbia, that this is a common definition: the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and hence to improve the quality and effectiveness of health services. Sorry about that. So I think for many, many years, we've been wondering as researchers, why are our treatments not moving into the community, and maybe feeling a little frustrated or a little I don't know, having some negative judgments toward our programs for not taking on our fabulous work. But once you delve into this line of work, you realize how hard it is to help these programs, even if they're already doing some of the work. There's a lot going on, right? A lot of barriers and facilitators. So now I'm moving out of the individual level treatment to programmatic level intervention. So we know medications are the most effective treatment for opioid use disorder, and there's a lot of barriers that continue. So the stigma of using medications such as methadone and buprenorphine, stigma of addiction, so many stigmas, stigma of going to treatment. But there's a lot of facilitators too. There's tribal communities that are concerned about mortality, and buprenorphine may be delivered in primary care. So that's very helpful, overcoming having to go to substance use disorder specialty clinics. And I should just mention that there are some wonderful Native programs, like up in Washington, the Swinomish have Digualich, which is a wonderful comprehensive program that is beautiful to be in, a beautiful location, has everything from transportation, housing, dental, a wonderful humanistic way of delivering the medication. So there are some wonderful examples out there as well. So for our study goals, it's a 2-phase study, and it's a formative study because this hasn't really been done with Native populations yet. So we worked with them to develop and test an implementation intervention to provide medications to treat opioid use disorder with American Indian Alaska Native consumers. So the phase 1, which happened quite a while ago now, as we're winding down, was to work in partnership with the collaborative board using the community-based participatory research methods to develop that culturally centered implementation intervention to support the integration of buprenorphine treatment for OUD. And then the next phase was conducting the preliminary test of the intervention in 4 programs serving American Indian Alaska Native communities using the step wedge design and mixed methods. So here is our original collaborative board, year 1, October 2019, pre-pandemic. We were actually in person in Albuquerque at the Indian Pueblo Cultural Center, and we had a wide variety of people to help us. So we had Native academics such as myself, Kate Hershak, Paulette Bacol. We had tribal leaders. We had tribal providers. We had people with lived experience who were Native. We had an ethnobotanist. We just had so many different people. It was just fantastic. So we had our one-time meeting in person, and then we formed into subgroups. So there was a group that I led that focused on traditional practices. What could we offer as a menu of options that treatment programs could consider? There was one that was measurement that was led mostly by Dr. Passionwolf, but also my right-hand person, Angel Vasquez. So looking through our measures, seeing if the items made sense, making sure there wasn't too much overlap, making sure we had good cultural measures. We had an implementation processes one led by Dr. Amy Campbell, looking at those processes and helping us with that. And then a publication committee. So Kate Hershak led the first publication and really worked well in, getting feedback from the collaborative board, seeing who wanted to be actual authors and contribute. So it's been a very rich, wonderful, favorite Zoom meetings ever. So these communities come from the state of Alaska. I think one of these little arrows got moved here. Sorry about that. Okay, well, don't look at the arrows. One is in Alaska, one is in the state of Washington, one is in the state of South Dakota, and one is in the state of Minnesota. So Washington and Minnesota and also Alaska have very high rates of problems with substance use disorders in general. And I just want to say, trying to find these programs to work with us was quite a task. I think other implementation projects, from what I hear, especially through the NIDA CTN Clinical Trials Network, they have programs that are sort of vying to be a partner, whereas we are kind of cold calling, reaching out to all our connections, calling. It's a lot more laborious process, but of course, very rewarding. Okay, so that brings me to the summary. So I think we're doing just fine with timing here. Always in my work, I have lots of things to balance and bridge. And one of them is looking at the challenges and health disparities that American Indian Alaska Native people face, along with the strengths of the culture, strengths of knowledge, Indigenous knowledge, and just trying to bring both the Western science together with the Indigenous science to create the best outcomes. People will try the treatment. People will have good measurement, because without measurement, what is our research, right? So that is a lot of work in assessment. So some measures now are valid with American Indian Alaska Native people. Some measures need to be culturally tailored and then tested. We may have to also develop some new measures. So not too long ago, the historical trauma measure was developed. Often I would say cultural constructs are not measured routinely in our substance use disorder treatment. Maybe if you're looking for mediators, spirituality is definitely one that comes up, particularly for the 12-step, which is supposed to be one of the active ingredients. But a lot of times they're not. And so I think just challenging ourselves to be more holistic, to consider culture, even for treatment outcomes, right? Maybe someone wants to get more engaged with their community, or learn some of the art, or participate in the dancing, or learn their language. So in the evidence-based treatments we have to offer, almost none of our evidence-based treatments explicitly include how to deal with culture or spirituality. So we really seem to leave it to the providers to kind of figure it out. So if you're not from that culture, I think it gets even harder. And I guess I would just encourage you to make mistakes. So I gave the land acknowledgement not knowing as much as I wish I did, right? And I guess my bias is to do something, even if you're making a mistake, is better than doing nothing. So I just think we need a lot more work to figure out how to help us know when to include culture and spirituality, which includes assessing the salience of cultural identity and spirituality for the client in front of you. And that can take some time. So maybe you don't have that much time. But I think any acknowledgement in the artwork you have that makes someone feel welcome, and to know that culture is important and valued is important. Cultural tailoring can increase adoption of evidence-based treatments, engagement, and retention in treatment. The lack of treatment effects when you have 2 active treatments is not too uncommon. And now I think implementation science is a wonderful way to bridge this gap between research and practice, and for us as researchers to learn from our community members what's important to them and what works for them. I really feel that a lot of my work has been generalizable to other tribes, other Indigenous groups, and even to the mainstream. I think I forgot to mention that, in the US, we have extremely high rates of people who believe in either God or a spiritual realm. I know it's gone down, but I still think it's at least 80%. And when you look in like psychologists, for example, that drops quite a bit. So there's a gap there that I think is unmet. And we might think, well, they can just go to some other religious leader, but I think being able to incorporate it and having more guidance there is important. And I think there's ways that in these adaptations, it's a whole different way of relating to people and caring for people and having greater compassion for the people that we serve. So I look forward to more work that maybe even looks at how this is helpful or well received, or when it's helpful for mainstream populations as well. I guess I left out my future work. So here's my acknowledgements to so many mentors that helped me along the way. being a first generation to college, I really did need those mentors. Everybody needs mentors. I have so many different collaborators from so many different places, wonderful graduate students, research assistants, postdoc, admin, funding agencies, NIAAA, NIDA, the NIDA CTN, even worked some with the Kellogg Foundation way back. Great gratitude to our collaborative boards who I think really helped us through the pandemic as well, the tribal councils and all the participants. So with that, I end my talk. I want to thank you with the Athabascan thank you, Chinan. And these are some moccasins that my dear late grandmother had made for me when I was a child. And with that, we will open it up to questions.